Hi guys, welcome to week 8. This week we're going to talk about the elbow, wrist, and the hand. This PowerPoint is up on Blackboard, so if you'd like to go back and go through it a little slower, but you always have that option through this video on YouTube to slow me down or speed me up in whatever manner is best for you. I know a little bit of background about this area. I know you guys haven't had a whole lot of eval content about this. That will come later in the semester. But I just want to hit on some basic anatomy and review some of that information that you might have taken in undergrad before you even got here. And also, I just want to go through a little bit of what you're going to do this week for your assignment. Okay, so first we're going to talk about the elbow articulations. So our bony articulations, much different than the shoulder, right? It's very limited. We've got 3 main bones that are involved, right? It's our radius, our ulna, and then our humerus, so the distal end of that humerus. It is a hinge joint, so with that hinge joint, we only have flexion and extension when it comes to the ulna and the ulna and the humerus articulation, right? The radius doesn't necessarily have a big impact in this articulation. Most of it is involved with the ulna, but that C shape in the ulna, right, our trochlear notch and that kind of olecranon area is what really keeps and makes this joint very stable. So we have the trochlea of the humerus articulating with the ulna, and the capitulum of the humerus articulating with the head of the radius. So a very little area of that capitulum, or of the distal end of the humerus, is articulating with the head of that radius. But you can see it helps, but the main stability is coming from the shape of that ulna. So like I said, flexion extension is about all we're getting here. Of course, we have pronation and supination, but that involves more of the articulation of the ulna and radius on each other, not so much involvement of that humerus. So with elbows, this is a very uncommon injury, right? Elbow dislocation. Often you put your arm down. We like to refer to it as foosh, falling on an outstretched arm, putting that hand down, not having proper falling techniques. Often very freak accidents where somebody isn't anticipating a fall, and the ulna can get pushed out, and the humerus comes out of that C shape in the ulna, and we have immediate dislocation. It is very hard to look at. I've seen one in my whole career, but it is a difficult one to see, and it is that posterior dislocation of the ulna that happens because the bony prominences really don't allow for any kind of anterior dislocation. So we have a posterior dislocation. It is an emergency situation, so you're going to want to refer. You want to call EMS if this happens, because and you do not want to reduce. At least in my experiences, reduction can be difficult and it's very painful because it's such a stable joint, and there are many important structures, if you think about it, nerves, arteries here, that we just do not want to compromise. So putting the person in some sort of air cast, vacuum splint, something like that, to maintain their positioning and very much getting their psychological health, keeping them distracted, I suppose, because shock is a big thing here. It's hard to look at. It's hard to see your own body. Often you'll have some tinting and sometimes breakage of the skin with this dislocation, just because we don't have a lot of extra area, extra room, and extra tissue around it to make space for a dislocation like this. So it's important that you focus on that with your patient. So some of our connective tissue in our elbow, right? We have the biceps, so our bicep tendon comes down and crosses, and a number of uh, whether it's the radialis, right, bicep radialis, any of kind of those bicep muscles, they're gonna cross, right? Then we have the posterior band, intermediate band, and anterior band, um, of mainly the posterior and intermediate of that UCL, right? Our ulnar collateral ligament. So this is very important, right? It's in the inside of our elbow, the medial side of our elbow. It's what we hear most related to Tommy John surgery, and is torn with our overhead athletes who are constantly stressing that medial elbow. You'll hear it a lot in tennis players as well, but you're gonna see the majority in our baseball, softball athletes. We also have the ulnar nerve that is in the same area. It runs more to the posterior side. It's your funny bone, right? It's when you hit it on the table or hit it on a doorknob or hit it on a corner, you instantly feel a tingling in your hand. And so that's what's really affected when you have that funny bone reaction, that ouch, and you want to rub and feel it. So understanding that when you're doing treatment in this area, if they're having nerve symptoms, that you may just be hitting that ulnar nerve. It is very superficial and can easily be touched or palpated, and you can create those radicular symptoms. So making sure that if you're having patients that are complaining of this, that you look at that ulnar nerve. There could be entrapment, especially with our upper extremity athletes. And then we have the annular tendon of the radius. I like to just refer to it as the annular ligament. On that wraps around, kind of keeps everything tight, and keeps a nice tight around the olecranon of that ulna. To go along, and we didn't really see it, but on the other side, obviously, we have an RCL, our radial collateral ligament, not hurt near as bad. We will have some overuse issues over there, specifically on the epicondyle of the humerus where it attaches. You might have some itis, opathy type symptoms, some constant pain, or some very little, like the inflammation type overuse injuries. So make sure you keep that in mind, that, our golfer's elbow is a good term, or tennis elbow. Those both involve the attachments up on the epicondyles of our humerus. So then, to make it pretty simple, right, we have our brachioradialis, which is going to be uh, affectionately called, our beer drinking muscle, right? It helps you pick up a beer and bring it up to your lips, or a cup of any kind of helps with that flexion. But then we have our wrist flexors, and then which are on the anterior side. Those are going to help our wrist flexion. This refers to it as forearm flexors, but I call wrist extenders, or on the posterior side, and all of the extensor muscles, and they come up and attach over on the lateral side, whereas all of our flexors, our wrist flexors, come up and attach on the medial side. So it's an easy way to remember, but for the sake of today, I'm just going to kind of go over those big groups, right? We have our wrist flexors, wrist extenders, and in those groups, they have small little muscles that come together and do a good job of our dynamic wrist movements. So some important wrist articulations. We have many bones that make up the wrist, right? Our carpals are very important. They have little movement individually, but as a group, help with the large articulation of the wrist. So our radius and our ulna, and this is the opposite of the wrist, right? Our radius takes on a majority of the movement and the articulation, where our ulna plays a very little role. It's much like the fibula in the lower leg with the ankle, where the talus and the tibia do a majority of the articulation at the ankle. Well, that's the same for the radius. So we have starting on the thumb side. So if you were to spread your thumb and extend it and you get a little triangle shape right at the base of your thumb, that's right where our scaphoid sits. So we have our scaphoid there, and then we have our lunate and our triquetrum, and those kind of are the bones that mainly articulate with our radius and our ulna at the wrist. So although that we're joined by other carpal bones, these are the ones that do the wrist articulation. It's also important to remember that we have an articular disc that sits right over the articulation between the lunate and our ulna, and that is called the TFCC. And so if you hear that term, it is just an articulating disc, much like our meniscus, similar in nature to our meniscus, that helps with kind of a cushion of the wrist. So the main joints there, with the lunate, the scaphoid, and the triquetrum. We also have our pisiform, right, in this, but it does little in the articulation, but with our ulna and radius make up the majority of it. As you can see, I wrote here, the ulna is not part of the wrist joint, and it doesn't necessarily articulate because of that articular disc. But there is a radial ulna joint at the distal end of the forearm. And it is important for that supination pronation that we talk about, right? Turning our hand over or flipping it up so we can hold something in our hands. So remember that, as that's the majority of its role. So what movements do we have at the wrist? Right? We have flexion and extension, and then we have an adduction and abduction. Now, often you'll hear abduction and adduction referred to as deviation. So depending on the direction, right? If we go with our thumb up, and like picture number 2 here, that is our radial deviation. So I always say thumbs up is rad. So rad radius. So that is our radial deviation. And then when we go up pinky towards the forearm, so it would be our medial deviation or our ulnar deviation. So just remember that. You can use the directions and where the bones lie to kind of help you with that.